That's the common assumption, yes.
And the standard dietary advice for FH has always been strict, low saturated fat, low cholesterol diet. But your sources provocatively call this, what was it? An evidence free zone.
That's a direct quote, and it's a critical point. Despite being the go to recommendation for
Right.
ages, there's a striking lack of evidence that a low saturated fat, low cholesterol diet reduces coronary events in FH individuals.
No evidence.
Yeah.
Seriously.
For reducing actual heart attacks or events in this specific group with that specific diet. The strong evidence just isn't there, according to these sources,
Yeah.
which immediately makes you ask.
If it's not just the high LDL causing the problems, what is driving the increased heart disease risk in some FH patients? Because not all of them get early heart disease, right?
That's right. And that's a huge question, especially for people living with FH. So, what are these other factors the evidence points to? Often overlooked factors.
Yeah, what are they?
Well, the evidence suggests that the subset of FH individuals who do develop coronary heart disease often show signs of what's called an insulin resistant phenotype.
Meaning their bodies aren't handling insulin well.
Precisely. This can show up as elevated triglycerides, maybe high blood. That's the long term blood sugar measure. Yeah. Obesity, high levels of insulin circulating, hypertension, those kinds of things.
Metabolic health issues, basically.
Exactly. And other crucial non lipid risk factors pop up too, like high levels of that lipoprotein, LPA. We mentioned it before. It seems to be a more robust marker for heart disease risk than LDL-C in these FH patients.
More important than LDL. Wow. Anything else?
Yes, increased hypercoagulability. Basically, their blood is stickier, more prone to clotting. They have higher levels of things like fibrinogen.
Okay, so clotting risk.
And these factors, the insulin resistance signs, the high LPA, the clotting tendency, they seem to be more important drivers of cardiovascular risk in FH, kind of independent of the high LDL itself.
So for someone with FH, just hammering down their LDL with a traditional diet might be missing the bigger picture. The underlying metabolic and clotting issues could be more critical.
That seems to be what this perspective suggests, yes. It really makes you wonder, doesn't it? How many other long held medical beliefs might be due for a similar reevaluation based on newer, more nuanced evidence?
Absolutely. Which leads us right into the question of diet overall. If insulin resistance and inflammation are so central, how can our food choices directly impact those things?
Well, the research we looked at strongly suggests that carbohydrate restricted diets, or LCDs,
Low carb diets.
right, especially those that emphasize healthy fats, can be a really powerful tool.
How so?
Clinical trials have shown that LCDs can lead to pretty significant improvements in cardiovascular disease biomarkers, sometimes proving superior to traditional low fat diets in certain measures.
Superior. How do they work?
They tend to work by reducing insulin levels, which then helps improve insulin sensitivity. That's key. They can also decrease how much sodium your kidneys hang on to, which can help with blood pressure.
And weight loss often comes with it too.
Commonly, yes. Weight loss is a frequent outcome.
Okay, what about the fat side of things? We've been told for so long to strictly limit saturated fats. That was like dietary commandment number one for heart health for years.
Right. Avoid butter, red meat, full fat dairy.
Exactly. But this research seems to challenge that too.
This is another area where some of the findings really push back against conventional wisdom. There was one interesting study mentioned on calorie restricted mice.
Okay, mice, but still, what did they find?
They found that the mice fed a diet high in monounsaturated and saturated fatty acids, specifically from lard. Interestingly, actually lived longer than mice on diets high in polyunsaturated fats like fish oil or soybean oil when calories were restricted.
Longer lifespan with lard based fat under calorie restriction.
Yes. Now, obviously, this doesn't mean everyone should start eating lard by the spoonful. It's a mouse study, specific context.
Right, caveats apply.
But it certainly raises the possibility that the types of dietary fat matter, and maybe in specific situations like calorie restriction, the effects aren't what we've assumed. That a blanket avoidance of all saturated fats might be, well, too simplistic.
Definitely complicates the picture. This also brings up that intriguing term I've heard more about lately, the lean mass hyperresponder phenomenon. Can you tell us more about that?
Ah, yes, the LMHR profile. It describes a specific pattern seen in some people, typically lean, physically active individuals, who go on a carbohydrate restricted diet.
What does their blood work look like?
They usually have very low triglycerides, often below 70 milligl, which is generally seen as great, and really high HDL-C, the good cholesterol, maybe above 80 milligdl, also considered beneficial.
Okay, low triglycerides, high HDL. Sounds good so far. What's the catch?
The catch, if you want to call it that, is that their LDL-C concentrations are often quite elevated, sometimes very elevated, 200, 300, even 400 milligdl or higher.
Whoa. So great triglycerides and HDL, but sky high LDL. What does that mean for risk?
Well, that's the interesting part. The combination of those super low triglycerides and high HDL in these specific individuals is thought to be associated with an anti-atherogenic potential. It seems protective.
Despite the high LDL.
Despite the high LDL, it really reinforces the idea that it's the overall metabolic picture, the context that matters, maybe more than just looking at LDL in isolation.
Okay, so given this much more complex, nuanced picture of cholesterol, inflammation, insulin resistance, how should we then view the mainstream pharmaceutical approach? Specifically, cholesterol lowering meds like statins, which are just so widely prescribed.
That's a critical question. And the sources you provide offer a pretty critical analysis.
How so?
Well, historically, looking back, clinical trials that aimed only at lowering cholesterol to make people live longer, they often had disappointing results.
Like what? Any examples?
Yeah, there was a study mentioned from the 1950s. Men at high risk of heart disease were given corn oil to lower their cholesterol.
Did it work? Did it lower cholesterol?
It did lower their cholesterol, but surprisingly, they actually experienced a greater rate of death or heart attacks compared to an untreated group.
Wait, lower cholesterol, but more heart attacks and death.
In that particular study, yes. It raises questions about just focusing on the number.
Okay, fast forward to today. Statins. They've been hailed as miracle drugs prescribed to millions. Given everything we've discussed, what's the argument for their widespread use now, or are the benefits maybe overstated sometimes?
Well, when you examine the benefits closely, some of the research describes them as, frankly, meager.
Meager, how so? Let's take a big trial like the Jupiter trial. That one got a lot of headlines, right?
It did. It reported very excitedly a 50% reduction in heart attacks and strokes for people taking the statin Crestor. Sounds amazing, right?
Yeah.
50% reduction.
Yeah, 50% sounds huge.
But here's where understanding the statistics is absolutely crucial. That 50% is the relative risk reduction, the RRR.
Okay, relative risk. What's the other side of that coin?
The absolute risk reduction, the ARR. In the Jupiter trial over 1.9 years, the ARR was only 0.9%.
0.9%. How does that compare to 50%? Explain that difference.
It means this. You would need to treat 95 patients with that statin for almost 2 years for just one single person out of those 95 to avoid having one of those major cardiovascular events, like a heart attack or stroke.
So one person benefits.
And the other 94 people, they took the drug for 2 years and derived no such benefit, at least in terms of preventing that specific outcome.
94 out of 95 get no benefit for that endpoint. That puts the 50% number in a very different light.
It absolutely does. And experts in biostatistics have really slammed the practice of emphasizing the RRR without clearly stating the ARR. They call it incomplete and misleading risk information. Some even call it a form of deception.
Wow, so the lesson here is whenever you hear about a drug benefit, you have to ask about the absolute risk reduction.
You really do. That 50% relative reduction sounds miraculous, but understanding it only helps 1 in 95 people.
Well, that completely shifts your personal risk benefit calculation, doesn't it? It certainly does. This isn't just about stats, it's about making truly informed choices about your own health. Okay, so the perceived benefit might be significantly exaggerated for many. What about the downsides? Side effects.
Yeah, there are definite concerns there too. Statins are associated with known adverse effects. Things like cognitive deficits, brain fog, memory issues, muscle injury, pain, weakness.
And didn't you mention diabetes risk?
Yes, a significant increased risk of developing type 2 diabetes mellitus. That's a major one.
Any other, maybe less known effects?
Well, research also shows that statin use can actually increase the body's absorption of cholesterol from your diet. Kind of counterintuitive.
Huh. And something about plant sterols.
Right. Statins increase the concentration of plant sterols, phytosterols in the blood. These are plant compounds that are structurally similar to cholesterol.
And that's bad because
Because they can get incorporated into your cell membranes, potentially making them less fluid, less flexible, altering their integrity. There's even a suggestion this might mess with how insulin receptors work.
so potentially contributing to insulin resistance.
It's a hypothesis being explored. And interestingly, a reanalysis of another big trial, the 4S trial, found something relevant to our earlier discussion.
Oh, what's that?
It found that statins provided basically no benefit to individuals who had that healthy lipid triad, often seen on low-carb diets, the high LDL, low triglycerides, high HDL pattern.
No benefit for the lean mass hyperresponder type.
It seemed that way in that analysis. Any benefits seen in other groups in the trial were likely due not just to lowering LDL, but to the statin's other effects, what are called pleiotropic effects,
Meaning?
meaning effects beyond just cholesterol lowering. Statins have mild anti-inflammatory and anticoagulant blood thinning effects. Those might be where the real, albeit small, benefit lies for some people, independent of the LDL reduction itself.
Okay, what about the newer drugs, the really potent ones like PCSK9 inhibitors? Are they a potential game changer with fewer downsides?
They are certainly very potent at lowering LDL-C, no question. They achieve a robust reduction. They also modestly reduce those triglyceride-rich lipoproteins and slightly bump up HDL.
Sounds good on paper. Any concerns?
Well, the research you shared raises a concern that this very powerful reduction in circulating lipids might come, and I quote, at the expense of lipid accumulation in the liver, pancreas, and heart.
So clearing lipids from the blood, but maybe they're building up in organs instead.
That's the potential worry suggested. And looking at human demographic studies people with natural genetic mutations that mimic what these drugs do, specifically PCSK9 loss of function variants.
What do those studies show?
They show complex relationships, including, interestingly, an increased risk of diabetes and visceral obesity that's the dangerous fat around the organs.
Increased diabetes and belly fat risk from a genetic variant that lowers LDL.
That's what some of those demographic studies suggest. So while these drugs are powerful LDL lowers, the concern is they might have unintended consequences on overall metabolic health down the line.
Wow. Okay, this whole deep dive has really truly challenged the conventional wisdom around cholesterol and heart disease. It paints a far more complex and, frankly, much more intriguing picture.
It really does. And if we try to connect this back to the bigger picture, it suggests something important about knowledge itself, doesn't it?
How so?
That knowledge is most valuable when it's really understood and applied thoughtfully, moving beyond just fixating on a single biomarker like LDL.
And embracing a more holistic approach.
Exactly. Thinking about the intricate interplay of overall metabolic health, inflammation levels, your body's own natural healing capabilities.
Yeah.
It's all connected.
So, wrapping this up, what does this all mean for you listening right now?
Well, hopefully it means feeling empowered, empowered with a deeper understanding of how your body works.
Encouraging you to maybe question some long held assumptions?
Definitely. And to consider multiple perspectives when you're making health decisions, especially around diet and lifestyle.
It's about being an informed participant in your own health journey. So let's leave you with a final provocative thought to mull over.
Okay.
What if our decades long, persistent efforts to drive cholesterol levels down to ever lower numbers, especially using pharmaceuticals, what if that's not just ineffective for many people, but maybe, just maybe, it's actively interfering with the body's essential functions, including its ability to protect itself and, crucially, its ability to facilitate repair?
Eye opening, to say the least. I am convinced that cholesterol is not a significant factor. Might be a factor, might be an associated risk that has very minimal effect on the whole picture, but atherosclerosis probably is a multifactorial disease. All right, so we have 10 minutes to 5 o'clock, and I still have a slide presentation to give. So I'm gonna do that. I'm gonna give you permission to basically leave if you have to, because normally we do this 3 to 5, but the recording will include the whole session and you can always watch the presentation later. Okay. Before I do that, I'm going to give a chance to those who, particularly if you are going to leave and you have a question, I want you to ask it now. And if not, you can watch the whole presentation later. You can even start after you leave and not have to rewatch the whole thing. All right. Any questions? Like I said, go ahead and okay, Mary, I see you. If you have to leave, please, I apologize, but this happens to be probably the biggest issue keto carnivore diets ever have. The biggest as far as especially the detractors, the people, oh, it raises your cholesterol. And so you have to be prepared. By the way, I suggest that if you ever talk to a client that is dealing with this issue and they are using statins, obviously you're not doctors, so you cannot recommend to anyone because you'll be practicing medicine if you tell someone don't take statins, but there are ways to ask about how you feel about taking statins, how you feel about not taking statins, whatever. But if you're going to continue to take statins, you can also and should also ask, are you taking coenzyme Q10? Many doctors will add coenzyme Q10 to statins because statins decrease the coenzyme Q10 levels. This is a very soft way of suggesting maybe they should be taking coenzyme Q10. Mary, go ahead and ask your question.
Okay. I just realized I was unmuted while I was moving those boxes. Sorry. I was probably making noises a minute ago. Anyway, I was looking for the book that we're supposed to start reading of a particular book that was Dr. Kiltz's book that you said to start reading, and I couldn't find it, a link to it, and I wrote down, oh goodness, in
So
my
one of the books is called Living Your Best Life, and I understand the links are already in the website, but
I looked for it. I didn't see it, but
and
okay.
The other one is called Daily Inspiration.
Okay.
And they're both, as I understand it, on the website. I apologize. I don't deal with the technical aspects of where things are linked and where they are put. I just give them the instructions of where to put it. Not even where to put it. Just
I understand.
Provide the materials for them to put. So
I'll look again. I looked all over and I couldn't find it.
I believe someone else had mentioned that they found it. Has anyone else found the
Mary,
link
if
to?
you look under course materials on the website.
Under course
the
material.
All right.
Okay, maybe I was just looking for the wrong thing. Okay.
Yeah. And
Under
the books,
course
the books are Living Your Best Life,
I
and the
wrote
other
it
one
down.
is Daily Inspirations. They're both of them. By the way, I think I found one of them on my local library through the app, and I think it's the Daily Inspirations. I downloaded it to read, to listen to it on my trip. But Living Your Best Life and Daily Inspirations are the two books.
Okay. Very good. Thank you.
Okay.
All right. I'm at work, so I am going to go, but I'm so glad that you're recording it. Thanks. Bye.
Okay. Bye-bye. All right. So let's do this. And all right. Can you see the screen?
Yeah.
Ketogenic, low carb, high fat, carnivore diets and the cholesterol issue. Okay, so that's the title, and From Fear to Function, Understanding Lipids in a Low Carb Context. Okay, all right. So as future health coaches specializing in low carbohydrate ways of eating, you will be inevitably faced with a major hurdle with your clients, and that's going to be the cholesterol question. I mean, it is the most common things. You can probably vouch for that in your own personal lives. Most traditional doctors even accept the fact that may be the best way to handle, for example, type 2 diabetes, but they'll still question the cholesterol. A client starts with a ketogenic diet, they lose weight, their energy is fantastic, their brain fog lifts, their blood sugars normalize, and then they get their blood work back, and the doctor calls alarm because their total and LDL cholesterols have gone up, right? It's probably a common scenario. This single issue is one of the biggest sources of fear and confusion, and it causes many people to abandon a lifestyle that is otherwise profoundly benefiting them. Our goal today is not to dismiss cholesterol, but to understand it. We will move from the simplistic good versus bad narrative to a more sophisticated functional understanding on what's happening in the body. Okay, so let's define some of these terms. Low carbohydrate, high fat. I think everybody knows what that is, and most people will agree that a low carbohydrate diet is generally under 100. Some people put that up a level to 130, and it's a diet that focuses on whole foods. A ketogenic diet typically needs to be under 50 grams per day to induce nutritional ketosis, where the body primarily uses fat and ketones for fuel. If you really want to be ketogenic, most people will be ketogenic under 20 grams. Some people at 30, 40, or 50 will be making some ketones that are detectable. By the way, ketosis is happening all the time. You just ramp it up when you restrict the carbohydrates. And a carnivore diet basically is a zero carb or near zero carb approach, with the exception of someone who's adding a lot of dairy or a big amount of eggs, for example, because there's a minimal amount in eggs approximately 1 gram per egg of carbohydrates, and there is substantial amounts in dairy depending on what you're consuming, whether it's milk or kefir or heavy whipping cream, or if it's cheese. Most hard cheeses have less than 1 gram or near 0 grams of carbohydrate, whether you're consuming yogurt or this sour cream. All these things do have a certain amount of carbohydrates. So you could be still carnivore, strictly speaking, because these are animal products, but you might be consuming 10, 20 grams of carbohydrate a day. So the metabolic principles we discussed today apply across this entire spectrum. The lower the carbs, the more pronounced these effects can be. All right. So what's the traditional view, right? First of all, cholesterol is essential for life. Without cholesterol, you would die. I don't think it's even close to exaggerating the importance, being that cholesterol is so important that every cell in your body can produce it. Your brain is at least around, and the numbers vary every time I look this up. There are variations on the number, but about 40% of your brain is fat, and more than half of that is cholesterol. Steroid hormones, all the sex hormones are based on cholesterol. Vitamin D is based on cholesterol. Bile acid production, which is essential for digesting and absorbing fats in the small intestine, is based on cholesterol. Every cell membrane of our body has cholesterol in their cell membrane. So cholesterol can be bad if it's that necessary, being that if we had no cholesterol in our body, then we would be dead. We certainly need cholesterol. So these things about bad cholesterol and good cholesterol, actually what they are describing is not even cholesterol, because HDL is a lipoprotein and LDL is a lipoprotein. So there's no such a thing as good and bad cholesterol. The lipoproteins are the passenger bus or the train that is moving the cholesterol around. All right. So why the bad rap? This goes back to the mid 20th century and the diet heart hypothesis, most famously promoted by Ansel Keys. The simplified hypothesis was eating saturated fat raises blood cholesterol, which clogs the arteries and causes, therefore, atherosclerosis, and therefore causes heart attacks. It is not that simple. Now, this led to the focus on standard lipid panel, and the standard lipid panel includes a total cholesterol, a HDL cholesterol, which is actually the high density lipoproteins that carry cholesterol, LDL cholesterol, and triglycerides. That's what normally is measured in the standard lipid panel. Triglycerides are the primary form of fat that is stored in the body and is transported in the blood for energy. Now, I don't know if it says it in a future slide, so I'm going to mention it now. Why do we need these transport molecules? Is because cholesterol and triglycerides are not soluble in water, right? We all know oil and water don't mix. Well, these are fats and they don't dissolve in water, which is blood is water. So we need the transport molecules, which is the high density lipoproteins, the low density lipoprotein, the intermediate density lipoprotein, the very low density lipoproteins, to transport cholesterol, triglycerides, and multiple vitamins and minerals and antioxidants as well. They don't only transport cholesterol. So the new paradigm, right? Imagine the body has two different economies, a sugar burning economy and a fat burning economy. Basically, when you have a high carbohydrate diet, you're using that fuel. When you restrict that on a low carbohydrate diet, you're pushing your body to use fat, and the energy needs to be delivered to the cells of the body, and that's where the fatty acids come in. The fatty acids, three fatty acids with a backbone of glycerol make a triglyceride. So this is why you need the transport system, which was here on the next slide. Okay, my slide is not coming up. All right, so this might be a difficult concept to sometimes visualize, but if you're thinking about passenger buses, for example, makes it a little bit easier. So let's follow the energy. The energy, remember, is the the fatty acids that are part of the triglycerides, and the triglycerides and cholesterol being transported back and forth from the liver to the cells and sometimes get stored. So the liver packages triglycerides, the fuel, and some cholesterol, the structural component. By the way, cholesterol is not used for energy, it's the fatty acid, into a large molecule or particle called very low density lipoprotein. This is our fully loaded delivery truck. The VLDL leaves the liver and travels through the bloodstream to tissues that need energy, also heart and other organs. At the cell surface, an enzyme called lipoprotein lipase unloads the triglycerides from the VLDL truck to be used as fuel. As the VLDL unloads its cargo of the triglycerides, it shrinks and becomes denser. It transforms from a VLDL to an IDL, intermediate density lipoprotein. Finally, that one turns into an LDL, the infamous LDL cholesterol particle. But remember, all these lipoproteins are transport molecules. By the way, sometimes when the fat gets absorbed, it doesn't go through the liver. It forms chylomicrons that are very large transport vessels or buses, and then that gets transformed into the VLDL, and this same process that I just described happens. The VLDL delivers, becomes intermediate density lipoproteins, and then LDL. So the LDL particle is simply the remnant of the VLDL particle after it has delivered its fat energy. Now let's apply this to a person on a ketogenic diet. And it's very important that you understand that context always matters. A high-fat diet may be atherogenic in the context of a high-carbohydrate diet as well, okay? Whereas in a low-carbohydrate diet context may not have the same effect. Anyways, so they're not using glucose, they're using fat 24/7, and this means their body needs to constantly be sending out VLDL delivery trucks from the liver, loaded with triglycerides to fuel their body. What is the logical consequence of having more VLDL trucks making deliveries? You will have more empty or emptier remnant trucks, which are the LDL particles. Therefore, a rise in LDL cholesterol on a low carbohydrate diet is often an expected and normal sign of adaptation to using fat as a primary fuel source. It is not a disease state, it is a sign of high functioning lipid energy transport system. All right, so understanding everything I just said makes it easier to understand this part about the lean mass hyperresponders, which is a phenotype that really has been discovered in recent years. And by the way, there's still among the cholesterol skeptics, they might have a different opinion on the lean mass hyperresponder, but this is the explanation. They are typically lean or fit, even though it's not part of the definition, that their BMI probably is close to 25, if not under 25. But when lean people who are lean or become lean through a low carbohydrate diet, very often their LDL cholesterol skyrockets, often over 200, which is the limit, the part of the definition being LDL over 200, but the LDL could be 200, 300, even 500. HDL goes very high as well, often over 80, and that's also part of the criteria to define a lean mass hyperresponder individual. And then triglycerides go very low, under 70. So if your LDL is over 200, HDL over 80, and triglycerides under 70, you are a lean mass hyperresponder. This triad is the hallmark of the lipid energy model in full effect. It's a sign of extreme fat adaptation and excellent metabolic health despite the alarming LDL-C number. Because remember, basically you are needing to deliver more cholesterol, and you start with a bunch of VLDL, you deliver the cholesterol and triglycerides, and it becomes LDL. I hope everybody is following so far. All right, so what really matters, and this is something that you may have to do with some of them when you explain this to them, basically coaching them through the numbers. So if a high LDL cholesterol can be normal, how do we assess risk? Okay, well, we look at the context and the pattern. We teach our clients to look at the bigger picture. The poor man's evaluation of insulin resistance is the triglycerides and HDL. You want your triglycerides to be under 100. You want your HDL to be over 50 at the very least. 150, that gives you less than a 2.0 ratio of triglycerides to HDL. The lower your triglyceride, the higher your HDL. That ratio will be definitely lower than 1. And if it's definitely lower than 2, but if it's lower than 1, that is optimal. That's ideal. Okay. And most people on low carbohydrate diet, whether it's near 0 carbs or 10 or 20, will probably see those triglycerides drop to below 70, below 50 sometimes. Okay. Someone took a look at the Framingham Heart Study data and realized, and I don't have that particular evaluation here, but realize that if your triglycerides are under certain number, your HDL is above certain number, then it didn't matter the LDL cholesterol, what it was, there was no more risk of cardiovascular disease associated just to the LDL cholesterol. So if you want to go to the nitty gritty, if you want to be more specific, and some people may need to do this to understand the real risk of having any type of cholesterol. So this is what they need to do. An NMR, lipoprotein fractionation, and different labs will call it different ways, but basically it will be a particle count, NMR, because you use nuclear magnetic resonance to do these measurements, and fractionation because you then measure different lipoproteins and you measure whether they are large and fluffy or small and dense. In particular, the LDL large and fluffy normally will go up with a ketogenic diet, but the small dense LDL will go down, okay? And these are associated with also with insulin resistance, high carb diets, and inflammation, the small dense LDL. They are smaller and they can penetrate more easily into the arterial wall. They are more susceptible to oxidation. And maybe it is partly true that a high LDL cholesterol could be atherogenic when we're talking about the small and dense LDL particles. You will only know what the status of those particles is with having a blood test, which is normally an NMR, lipoprotein fractionation or evaluation. Okay, so on a well-formulated low-carb diet, the LDL pattern typically shifts from dangerous small dense particles to benign large fluffy LDL particles. So for a client who's concerned or whose doctor is pushing back, more data is the answer. An advanced lipid testing or an MR lipoprotein or lipoprofile, different labs call it by different names. Basically, you're gonna measure multiple particles, in particular the LDL particles. An ApoB needs to be ordered in addition separately, but it's closely associated with the LDL particles, and this number could be high. The total amount on a lean mass hyperresponder, okay? But you're also going to measure the different sizes. And like I said, the small dense should go down, the large and fluffy particle numbers should go up. You also
Sorry,
measure,
Dr.
yes.
Nelson is so generally APOB is a concern, but did you just say in the lean mass hyperextender it will be high and less than of a concern, or can you clarify?
So
ApoB.
yes, the ApoB is closely associated with the numbers of LDLP. Okay, there is something here that can be confusing. It's not on this slide because the pattern B and the pattern A have to do with the sizes. Okay, but it is a test that needs to be ordered separately, even though you want to do it at the same time. It is not within the NMR lipoprofile panels that normally measure things. The ApoB has to be ordered separately, and the ApoA has to be ordered separately.
But that
Okay.
correlates, a high ApoB correlates with
Notice,
the pattern
notice,
B.
yeah, notice here should be taken individually, is the message. Just like we saw before that we shouldn't rely on just LDL cholesterol by itself without taking into account diabetes, metabolic syndrome, hypertension, smoking, obesity. This is actually the same issue. No individual test should be taken independently and uniquely to determine risk.
It
In
could be
general,
elevated due to other inflammatory causes, stress,
yes.
or overexercising or whatever.
Well, if you read the line, it says that the ApoB will also be high in lean mass hyperresponders, just like the LDL. So it's not really
Yeah.
telling us anything by itself. That's why we need the other tests to go along with it.
So inflammatory markers, which is something that I recommend that also are done. But again, we don't evaluate this by itself. Yesterday, I was talking to one of you. I'm not going to mention the name, but he had a very high CRP, and it is better, but it's still considered slightly high. But again, we don't take that by itself. And if you remember the 12 items, actually inflammatory markers were the number 12. So yes, in context, but not there is no number that by itself should be used. All right, so the ultimate tiebreaker, the CAC score, and the CAC score is just the first test on a chain of tests that you may need to do. It's excellent for screening. What does it measure? Okay, this is a simple CT scan of the heart that directly measures the amount of calcified, hardened plaque in your coronary arteries. So what it doesn't measure, which is didn't say it there, it doesn't measure any soft plaque, okay? But if you get a CAC score of 0, you can almost take it to the bank that you're not at risk of having a significant event, the two major events being heart attacks and stroke, right? It is not a proxy for or a risk factor, is that basically a direct measurement of existing disease. Many LMR, lean mass high responders with sky-high LDL have a CAC score of 0, indicating not detectable atherosclerotic disease. This provides powerful evidence that their high LDL is not really causing harm. So in the case of Diane, if her CAC score comes back at 0, great. If it comes back anything but 0, then there'll be a certain risk associated with that number. And then probably the next best test to do would be either one of the two I'm going to mention or both. CT scan angiogram with artificial intelligence overread, which is something done just by one company, as I understand it clearly. And the other test would be a CI carotid intima thickness test. Maybe I have that on. Okay. So why? Because that's an ultrasound. It's also a test that needs to be done by someone who has experience doing it. But anything that's happening in the carotid artery is most likely happening in the coronary artery. Okay.
So what about seeing small plaques in a regular, say, carotid ultrasound?
Well, if you're already seeing plaques in a regular carotid ultrasound, basically you have some level of atherosclerosis.
Like that would be like soft plaque, like they say.
No, do not. It doesn't say anything about soft plaque. A carotid ultrasound will not tell you anything about soft plaque. The best test for that would be a CT angiogram, and it will tell you whether it's with the artificial intelligence overread. Not all CT angiograms will report soft plaque, okay? But the soft plaque is thought to be the unstable plaque that can cause problems, okay? So calcified plaques are more stable plaques. But if you have calcified plaques, it means you have a process going on in your arteries. And now it's trying to determine how much of a process has been going on. All right. This is in particular for coaches, the approaches, the bridge from motivation to action. Don't rush into planning before the client is committed. I was going to have a lecture on motivational interviewing before this cholesterol lecture, but the person I invited to do it cannot do it until September, so I had to switch the lectures. And I hope you like this. Motivational interviewing is going to be done by someone who has been a coach for several years. So I'm not going to even say the name because until it happens, I don't want to jinx it. Anyways, When you talk to a client, basically, you're not telling them what to do. You're helping them. You're pointing out things. You're asking them questions for them to provide their own answers, basically. Okay. This is a collaborative conversation about how the client will make the changes, and then focus on small, specific, and achievable action steps that are client led. Okay. So, all right. So, conclusion, your role as a coach: reframe the narrative. High LDL cholesterol and a low carbohydrate diet is often a feature of fat adaptation, not a bug. Focus on the pattern. Teach clients to celebrate low triglyceride to HDL ratio because it is very important for two reasons. Number one, a low triglyceride, a high HDL. If your ratio is under 1, you have very little evidence of insulin resistance, which is probably the main problem causing the atherosclerosis. High sensitivity CRP, although you have to be careful with that one because, as you saw on the one study of the Women's Health Initiative, the correlation with heart disease is very minimal. It is an important marker to track if it's high, but again, it's not the main thing. Obviously, you empower your clients, you don't prescribe anything to them, and you don't prescribe a diet even, unless you are a nutritionist or dietitian with a degree. You need to stay away from prescribing even a diet. You provide your clients with information and the questions to ask their doctor. You might anticipate the doctor objections and give them information for that. And you always reframe the questions about what will you do? How do you feel about this? What is your plan? You're not there to give them a plan. You ask questions so they formulate their plan. Yes, you're guiding them. You are not there to tell them. And maybe that's something that has changed among coaching and many other professions. We need to stay away from telling them the paternalistic approach to, and that's how I learned when I studied medicine. I went to medical school between 81 and 84. And it was, you can probably say most doctors, even to this day, might approach medicine as a very paternalistic way, right? You're going to do this, this, and this without consulting the patient on what they want to do, unfortunately. Gather more data, encourage clients to have informed conversations with their doctor about advanced lipid testing, or most importantly, a CAC scan, if they want to determine whether they have atherosclerosis. Don't rely on the cholesterol. Cholesterol is not a disease. It's just a level may imply a degree of risk. And I think, as I have showed you, may not be at all important, but even if it is, probably is very minimal its degree of importance compared to insulin resistance, having diabetes, metabolic syndrome, and all these things. Okay. So help them find low carb literate physicians and resources. It is very difficult. And there are many societies, many communities that do have some registered low carb practitioners. I am a member of the Society of Metabolic Health Practitioners. They are the ones, together with the United States chapter, Low Carb USA, who's sponsoring the conference I'm going to tomorrow, and Dr. Kills will be talking there, the Symposium for Metabolic Health. There are other organizations and other communities that have lists of low carb keto providers, but the truth is it's very difficult sometimes to find them. And they're well-known individuals that they don't take insurance, but they have different programs to help you. Dr. Tro with Dr. Buchanan has an online telemedicine, no insurance program. Actually, it's not that expensive. Dr. Ovadia, it's also without insurance. Dr. Robert Sives as well. Dr. Boss has a different type of practice. So she's concentrating on teaching a lot. Twice a year, she has the 21-day metabolic kick, and out of those, she may select patients. She's not open for you to walk off the street and become a patient. She has a different type of practice, basically. So the conversation around cholesterol is evolving rapidly. It has certainly evolved for me, although I've never been a big cholesterol believer in the sense that my grandfather ate a dozen eggs every day. He had chicken, so eggs were free, and his cholesterol was normal. But you've learned today puts you at the forefront of this new understanding. Is a paradigm shift, if you would. Your confidence and knowledge will be the most valuable tools you can give your clients when they face this challenge. You're equipping them to take ownership of their health base on a complete picture, not just an out of context number. Basically, context matters, and maybe cholesterol issues on someone who also has a very high carbohydrate diet might not be a good combination. All right. So do we have any questions? Let me see if I had some questions here. See, these are examples. Now it's 5:37. We can leave these examples for next week, or we can take some of these questions now. Bob.
So when we talked about the CAC score,
Yes.
and we often bring up that, if you're concerned, go get your CAC score and see what those values are. And if those values are 0, you're probably doing pretty good. Now, a traditionally trained cardiologist or doctor is going to come back at you with that. Well, that CAC score only measures calcified plaque, doesn't measure the soft plaque, which is the plaque that could break off and plug you up in your brain or in your heart and cause an issue. What is the thinking behind a 0 CAC score? Is it just statistically the odds are if your CAC score is 0, you have very little soft plaque as well?
So, Bob, you have hit on something that is universal in medicine. All we do when we're with a patient, me as a doctor with a patient, is assess risk when we're talking about preventing a heart attack and or a stroke, right? So we take all the factors into consideration. And so the answer is yes. If you have a CAC score of 0, I cannot tell you that you will never have a heart attack, but the chances are very, very small.
Mm-hmm.
When you get into a car, you know that there's a risk you can have an accident and lose your life, but you decide to take that risk. So it's kind of a similar thing along those lines. If your CAC score is 0, by the way, mine isn't, it's 135, 165. And my cardiologist said, oh, no problem. He did do because of an unrelated thing, he wanted to do a stress test. So I did it. I was perfectly fine. But just on the CAC score, don't worry about it. You're 8. Just keep your LDL under 70, which actually is not what he's of the belief that if your LDL is low, you're safe from all cardiovascular risk. I don't agree. But my LDL was under 70 and my CAC score was, and he decided at the moment not to do anything. But yes, it is a matter of risk. Doesn't matter what your cholesterol is, because cholesterol is just a number of the cholesterol, right? And by the way, they're mostly measuring the lipoprotein. So they're measuring the amount of buses that have cholesterol on board, if you understand the analogy. But if you're thinking that, oh my God, this is what's going to kill you because your LDL cholesterol is 101, then the correct approach should be, okay, let's do a CAC score. CAC score proves that there is no measurable calcifications. Your chances of having soft plaques to the extent that it's going to cause an event is almost nil. So yes, it's a matter of assessing risk. And someone with a CAC score, I wouldn't necessarily go further unless they wanted to, okay?
Mm-hmm.
Now, at this point, though, with a CAC score of 0, if I try to order a CT angiogram with the AI overread, I might have a hard time convincing the insurance that they need that test when the CAC score is 0. Okay, it's going to be easier if I have a positive of any number CAC score. I can put on the patient's chart with a CAC score anything other than 0. I can put on the patient's chart coronary artery disease. I have proof that there is coronary artery disease. Even if it's minimal, I have proof. And with that diagnosis, then I'll fight any insurance company to cover this test that I'm asking, because then I have proof that it's indicated.
Okay, so
That is also further risk assessment.
mhm.
Regardless of how it comes back, it is further risk assessment. A CIMT is further risk assessment of the degree of any other vascular test. Once I know that they have atherosclerosis, is further risk assessment. And then we can determine whether we are at a point where we need to be aggressive, taking measures that may reverse that process or not. Go ahead. You were going to say something else, Bob.
Yeah, I was gonna say what your comment about, what we're trying to do is assess risk makes sense because I've also heard of experiences where people will have a clean test or they'll take a stress test like you mentioned and they'll pass with flying colors and then 3 days later have a heart attack because
Yeah.
they have a poor diet, they're overweight, they're diabetic, they've got high inflammation markers and other things that they weren't looking at. So
cholesterol is not the only measure. Even a CAC score is not the only measure. Like I said, you cannot take any test. It applies to every single test. You cannot take them individually unless the test is pathognomonic to a specific condition. What does that mean? There are tests or pathology reports that show something that only happens in this condition. We call that pathognomonic. In other words, if that appears, you certainly have this condition. When we're evaluating cardiovascular disease risk, we're mostly concerned about the acute stuff, not the chronic long-term problems. I tell you have atherosclerosis, and yes, you might be worried, but I'm not telling you you're going to have a heart attack tomorrow. I am trying to avoid, if you have atherosclerosis, that you have a heart attack or a stroke tomorrow. This is where multiple strategies will come into play to avoid that. But with a CAC score of 0, you don't have any evidence of atherosclerosis, and it's very unlikely you have any significant soft plaque and have no calcification. Is it possible? Of course it's possible. And this is why, for example, a stress test may not always be the most reliable test to predict a heart attack or any event. As you mentioned, it's not uncommon. Happens all the time. You have a completely normal thallium, nuclear medicine stress test, or you did it doing the exercise, which is always more reliable, but not everybody can do it because by the time they're needing to have that test, they're probably so decompensated in so many other things that doctors will go ahead and do the nuclear stress test. And you can pass it with flying colors and die of a heart attack the next day. It's almost the same thing with cholesterol. Maybe you have 500 of total cholesterol and 200 of LDL, and you don't have a heart attack, or you can have 170 of total cholesterol with an LDL of 80 and have a heart attack. And I've seen 2/3 of the patients that have heart attacks have either normal or below normal cholesterol, not high.
someone reminded us if you could stop sharing your screen so we can see you better, that'd be great.
Okay.
And then I'm
Well,
done.
the thing was because I have more slides.
Okay.
But I was asking, and it's okay. Your question is definitely appropriate. I have more slides, and they are examples of questions with the answers that may present to you as a coach. And my question was going to be, it's 5:47 now. I don't want to go beyond 6 because that's going to be a 3-hour Zoom call for you to review it. We can cover 1 or 2 of these. Let me see how many I have because I'm on slide 22 and I have, I think, 30 slides. So I have a few slides that we could go to, or we could just stop here and continue answering the questions we may have right now and leave the Q&A for next session.
Susie had a question.
Susie, go ahead. Let's do that. I'm going to stop sharing. We're going to leave these examples I have there for next time. And we can I'm going to do a hard stop when that hits 6 o'clock. Okay. So we don't make it more than 3 hours, trying to be considerate to the ones that are going to have to review it later. And I still have more information for next time. So Susie, go ahead.
Okay, thanks. I just wanted to know if that CAC test also used as an indicator of stroke risk. And are there any other tests that are good for that?
So what happens in the coronary arteries, the thought is it's going to be happening everywhere you have arteries, but you cannot substitute it for the stroke risk. Now, a stroke and a heart attack are the same process, so the risk is very similar. The reduction in risk is very similar when you're talking about reduction by either medication or any other strategy. You're decreasing cardiovascular events. So the main cardiovascular events are heart attack and strokes, kind of the same process. One is a heart attack, one is a brain attack. Okay. Now, in the brain, we also have often the atherosclerosis causing an occlusion that's usually called an ischemic stroke, which means decreased blood flow. But we also have hemorrhages. Those don't happen that often in the heart. And the hemorrhages could be because of aneurysms, it could be because of tumors, it could be because of blood pressure, and may or may not involve atherosclerosis when that happens. So that's why someone that has a stroke goes to the emergency room, the first thing they're going to want to do is a CT scan without contrast, because if you have blood, the CT scan without the contrast will pick it up. And then if there's no blood, then you can proceed with giving the coagulation busters, medications, TPA and the like. But it's basically the same process. Heart attack, brain attack, we're talking about the same thing. So the risk is similar. Is it the same? No, it's not always the same. And the CAC score cannot be used to determine stroke risk.
Okay.
The
Thanks.
math doesn't always work the same. Diane, thank you,
Hi,
Susie.
Dr. Nelson. So I heard rumors that once you've been a carnivore for a certain amount of time, that your LDL might lower. Have you ever heard of that?
So the LDL doesn't go up on everyone that's low
Right.
carb. I mean, it's just a small, not a small, but
A certain phenotype or a certain.
it could be phenotype. It could be also a temporary thing. For example, I don't recommend anyone goes doing any testing within the first 6 months.
Right.
Because most likely you're going to catch them at very bad numbers you don't want to see. When 3 months later, they could have been better.
Right.
When your body sort of settles and adapts.
Okay.
So
you have heard of that happening, that your body kind of adapts and the LDL it goes high at first and then it comes down a little bit.
yeah, but
Okay.
not on everybody.
Right.
Some people, their cholesterol numbers just get better, period, and nobody has. Now, it is common to have mild elevations of LDL. This is what happens more often, probably. After you've been carnivore a year or two, and you check your LDL, that may not be 70, but it's 105, 110. Most doctors are not going to push that hard to give you a statin. Most doctors will probably, we got to put you on a statin. And if you say no, with 105 to 110, 120 of LDL, they're not going to push hard. They're going to push hard when it's 200 or 300.
Right.
But we explain how that happens and why I don't think, and most people in this community don't think, it's a good marker for predicting cardiovascular event, because there are so many other important things that need to be fixed. And remember, it's very simple to take a look in the same lipid panel, the triglycerides and the HDL. If that ratio is under 1, that to me is more important a predictor than the LDL cholesterol.
Right.
Even if the LDL cholesterol has an associated risk.
Right. So I had mine are the big fluffy kind, and my ratio is 0.7. So it's like, it's ridiculous that the doctors don't even look at that.
So you did the NMR, the lipoprotein fractionation?
I did it with a different functional lab.
Okay.
I did it on my own.
Okay. So you have the large fluffy particles, not the small dense.
Right. I know. It's really silly, all this testing,
Now,
right?
by the way, carnivore is not magic. Low carb is not magic. There are people that will continue to have small, dense, large amount of particles that have atherosclerosis, that may have some insulin resistance or not. And those are the difficult patients to make decisions on, because with all the bad rap that the statins have, they do lower the risk of a heart attack. Is it small? Yes, it's very small.
But it also
But it's statistically significant.
It also sets you off for brain disease, and where I already have MS,
I'm not.
I don't want to be.
I'm.
Yeah,
I'm not.
right.
I'm not saying so.
No,
This
no,
is
I hear
where
you.
individualized treatment is
Sure.
important. I'm not saying
Sure.
this will be a solution for you.
Right. And
This is
also
a
my CRP is higher because I have an autoimmune disease. So that
yeah.
that little piece, like they're trying to figure out all the different pieces, but they're not looking at the new way of doing things as far as, and I could just see like a client facing this, right? Because people come to us because they're trying to heal something, right? So they've got
Yes.
all these different numbers that are floating around out there, and it's a lot.
Yes. Okay. We have 4 minutes and two people who want to ask questions. So George,
Okay.
you do your best to be fast, but not too fast, so
Yeah.
I can understand.
Okay, mine is a quick response to Diane. I went low carb in March 2022. In January 2024, my cholesterol score, for want of a better word, was 7.1 in the UK, which is high 200s in the USA. However, when I went back in September 2024, it had dropped to 5.5 or low 200s. So that's the answer, Diane. Yes, in my case, it did drop. I have a theory that basically my body, I've been going for 3 years. My body had pretty much healed, so it didn't need to send out as much cholesterol to heal my body. That's my theory.
And you are probably correct. And that goes along with the comment that Diane was making, that sometimes if you just wait longer, those numbers will get better. Amy.
I'm not really sure why I raised my hand, except that I don't really like cholesterol. Is just a silly game in my opinion. But when I was carnivore 5 years, my triglycerides were 150, which is like the limit of being bad. And a year later, they were 75. So they change, and I didn't change anything that I was doing.
All right. So let me stop.
Is 140.
Let me explain that. I know you want to say more, but let me explain that.
Okay.
So triglycerides change as much as glucose does, by the way. Okay. Your glucose changes 10 times or 20 times or 24 times during the day. Your triglyceride number can do that too. So the amount of time fasting before the test is important. And yes, how long you have been carnivore, but you cannot always compare unless you have apples to apples. The comparison is not always like we think. You have to be 12 to 16 hours fasting to do a triglyceride test.
Oh, I was, but my HDL is always way high. It's 140 for some weird reason.
You have a wonderful HDL.
I don't know, but
all right.
I asked my doctor for a CAC score, and she wanted to do it because I had a high cholesterol. So she ordered it, but Medicare wouldn't pay for it, and I had to pay for it. And it was 104, so it's not 0, even though I've been carnivore.
All right. I am gonna search for an answer for the CAC score because I like finding out what Medicare pays for and what the correct codes are to use. I have fought insurance companies for many things like this a lot. Okay, we're coming to an end. It's gonna be 6 o'clock. I'm gonna ask Alia to cut it right here at the 3-hour mark. I'm still gonna stay here and answer any questions you want, but they're not gonna be in the Zoom for other people who watch it, okay? So we're done. You don't have to stay. If you want to stay and ask any other questions, I'll be happy to be here for a few more minutes.
Thank you,
okay?
Dr. Nelson.
Thank you. I'm exhausted. I gotta go.
Yeah. It's next week. Back on Wednesday at 3 p.m. Eastern time. I'll be in San Diego, so it's going to be noontime for me. So thank you for being here, and we're cutting it off right now. The Zoom call will not have any additional beyond the 3 hours, okay? But if you have, hold on a second, let me, all right. So if you want to stay, be my guest, and but for the ones reviewing this later, this is it, okay? All right. So, Diana, you're muted.
You still have to unmute yourself, Deanna.
Yeah, I had to shift to my phone, so I lost it.
Awesome.
I just happened to recently have a ultrasound done of like my neck, my abdomen, the whole shebang. And I have a 0 CAC, and my triglyceride to LDL ratio is under 1. So all of that looks good. I don't know if just tiny and it's or if it's a risk of letting go. It says in the right carotid artery shows an atheroma in the back wall, currently 2.6 millimeters length by 1.6 millimeters of posterior anterus diameter without obstruction process. So carotid artery is normal on the left. So it's just one tiny
One
is
spot there.
yeah, and then the thing, and then they don't describe this much about the abdominal aorta shows linear atheromas without obstructive process. So
The thoracic, the aorta's findings are very interesting because they have found, even in children that don't develop atherosclerosis, they have found some streaky stuff. I don't know if I would worry if it was me. Now, if you wanted to do a test, a CIMT will be the test to do. It's in the carotid, but it is not done by everyone. So carotid intima media thickness test, which is an ultrasound in specialized hands and with specialized radiologists that read that. So
probably something that I'd have to come out of pocket for.
it's most likely.
Yeah.
But it's commonly done. Like here in Deltona, one of the like Simon Med, I think, or one of these big companies across the country that they do it.
Right.
So it can be done. Now, the indication, the diagnosis code that the doctor uses and the insurance company covers, this is where you need to play with the system and find an appropriate diagnosis code.
Yeah, I've had a good doctor that has done magic with however he codes. I mean, I've asked for the most bizarre tests and I never get a bill. Other than I did pay for my CAC. But
I
yeah,
think
so it's like there's
I hope that
training.
it's gonna become. I mean, this is a test that has been around for a long time, but traditional insurances don't cover it, and hopefully, it's gonna become more common to be done and to be covered. But sometimes those are battles that
Yeah, well, absolutely. Just like fasting insulin. How much, these are inexpensive things to do for yearly or bi-yearly
we
quick
have been able
tests.
we have been able to measure insulin since the 1970s.
Yeah, crazy. And
So
then also, what about having, I mean, I want to see the day when at least yearly, if not twice, every 6 months, but yearly, to have a doctor prescribe the CGM, 2 sets of CGM, 1 month for people to observe what's going on with them. I mean, how quickly would that help people decide that they want to change?
Well, because of the cost of that one is going to be a hard pill to swallow, because if you don't use insulin, insurances don't want to cover it.
Right, but we need to shift the insurance paradigm.
Listen, you're preaching to the choir.
Yeah.
You're preaching to the choir. It's just that's the way it is right now.
Yeah. The one thing on the CGM that I experimented with a while back, which I tell my clients, is how much stress made the difference. I had a cup of coffee in the morning, and it was probably noon to 12:30ish, and I had a confrontation with one of my patients' nurse practitioners that didn't want to go to bat for this woman in her 90s. And she was just attacking me. And I know my heart's going pump, 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 pump. And later that night, when I looked at the CGM on the phone app, it went up to 160. And mine never had gone over 120, despite anything I could eat within my diet.
So what did that tell you?
That told me that people can be doing everything right with their diet. And if they're stressed out and, have a lot of anger issues or interactions, that they can create diabetes and metabolic disease and atherosclerosis, all the inflammatory things. It was like so obvious. I'm like, oh my God.
I went to give a talk about reversing type 2 diabetes in a church that was having a health fair on a Sunday, and I was fasting. I had a CGM, and I've been speaking in public. Listen, I have in first grade, and I never took kindergarten. In first grade, I had a play that we performed in graduation. I've never been, I've never had stage fright. I've never had a problem with speaking in public. And by the way, I played a doctor in that little play. So, okay, I am not the person that gets stressed about. I finished my talk and I sat down and I looked at my CGM. My blood sugar has spiked 30 points just when I went up to talk. So sometimes we don't even realize our bodies are responding to the situation, and whether it's because you're drinking coffee and I wasn't having coffee at that moment. It was just pure adrenaline that produced a sugar spike.
Yeah. Well, I should have been well into ketosis by the time, because the coffee was probably at 7:30 in the morning. It's now noon and I haven't eaten anything.
It happens. Our mood can do those things. All right. Does anybody else have a question? Please, if you have a question, I still see 20 people here. 19 with me. So if you have a question, now is the time. Bob?
So this is kind of in relation to a question that William Cook asked in the chat, and I want to see his proper wording here. But he asked the question, does blood...
He just had his hand up and put it down.
Yeah. He did, and maybe this is what he's going to get at. I don't know. William, unmute and chime in. But he asked, does blood pressure indicate how healthy your arteries may be? And so I thought that was a good question because, I've got the chronic kidney disease, late stage, and so I deal with hypertension, and it's not essential hypertension because diet doesn't fix it. Mine's obviously secondary hypertension that's a result of the kidney damage. And so I live with some I also... The triglyceride illustration I thought was fantastic, because my triglycerides will run high because I spill that lipoprotein lipase. So my triglycerides hang around longer than most people's. And so I've got that higher trig to HDL ratio. I've got the high blood pressure. And, my LDL's high because of my chosen dietary lifestyle as a carnivore. And I'm not too worried about the LDL, but the other two factors actually do worry me. And they worry me because someone with stage 4, stage 5 chronic kidney disease, people who have late stage renal disease usually don't die of kidney disease. They usually die of cardiac issues. So according to the mainstream, I'm a little more in that higher risk category. When we talk about assessing risk, I've got some risk factors there that are noteworthy. He asks the question, does blood pressure indicate how healthy our arteries may be? In my case, it probably would be an indication of the health of my blood vessels in my kidneys that have been damaged, and now I'm having a hard time regulating blood pressure. I'm taking olmesartan. I was taking losartan. I've recently switched to olmesartan. I'm taking the Bivalol as a beta blocker. I bumped it up a bit. I started taking nitric oxide precursors, and a bunch of efforts to try and get my blood pressure down, because to remain elevated in stage 2 hypertension bordering on hypertensive crisis, that could also potentially cause further kidney damage. So I'm kind of stuck in this downward loop. Everything's a catch-22 for me. And I don't know what else to add now. Maybe a calcium channel blocker. So this isn't really a coaching question. It's kind of like a personal health question. But his question made me think about that. My arteries, are they probably all around in bad shape, or could this just be isolated to the kidneys? What does my blood pressure reveal about me? What would you think?
All right. So
a lot to unpack there.
Yeah. So let's start with what I learned in medical school.
Okay.
95% of the people with hypertension, we don't know what causes it. It's idiopathic, it's essential hypertension, and we can search and search and we will not find. And only 5 to 10% has a secondary or primary cause causing secondary hypertension. Chronic kidney disease, arterial stenosis, whatever initiated the kidney problem, which could be a long list of injuries to the kidney of different kinds, autoimmune, infectious. A lot of people develop kidney problems after having infections.
Mm-hmm.
Due to autoimmune issues, due to diabetes because of damage of the vasculature. The main damage to inside the arteries, for example, in a person with diabetes is to that glycocalyx matrix that we were talking about in the live. I think you probably were in the live this morning, right?
Not this morning, no.
Not this morning? Okay. So glycocalyx covers the inside of the endothelial layers of the arteries and is the first layer to be inflamed and injured both by high levels of insulin and by high levels of glucose. Okay. So it's a double whammy when diabetics are not well controlled. This is how they develop kidney disease. The inside of the arteries gets damaged. Now, I've come to believe that 90% of, we don't know what causes it. Most of it is probably chronic excessive carbohydrate consumption that causes basically your body to retain fluids, inflammation. It causes changes in the hormone production of the adrenal gland, including aldosterone and antidiuretic hormone in the brain. I mean, there are multiple hormones always at play. Every system has multiple hormones that have feedback mechanisms, right? I never had problems with hypertension until 2018. Ended up having a stroke that year. My mother had hypertension very young, in her 30s, I believe. She developed hypertension. She's no longer with us, so I can't ask her how old she was when all started, but I do remember her taking medication for blood pressure in the early 70s. She was 35 in 1970. So anyways, so what do we know by the blood pressure about our system of arteries? The longer you have hypertension, the more chances you're going to be developing hardening of the arteries. And what's hardening of the arteries? Atherosclerosis. They become stiffer and stiffer as atherosclerosis gets worse. So the longer you've had hypertension for whatever reason, the more damage will be. It's interesting that we blame the cholesterol, right, for the heart attacks. But when we look at the arteries, if we look at a CT angiogram or a cardiac catheterization, most of the lesions are at the bifurcation of arteries where the pressure of the blood flow is highest. Whenever you have a bend in an artery, whenever another artery takes off, the blood pressure is at its highest turbulence right there. And that's where you develop atherosclerosis. What that tells me is one of the insults involved in atherosclerosis is the blood pressure. So if your blood pressure is under control, you are less likely to have cardiovascular events because your blood pressure then is not injuring that inside of the artery constantly. So blood pressure, for example, in your case, the blood pressure and your kidney problem, well, you can obviously say that your blood pressure is not well controlled, or to control it, you need multiple medications because your kidneys is having its say in the blood pressure. By the way, the kidney in the system of regulating blood pressure, which includes the heart, the adrenals, the kidneys, and the vascular system, the kidney is in charge. Okay. A lot of people think hypertension, heart. No. Yes, cardiologists have to know about high blood pressure, and actually the kidney specialist is the one that's supposed to be the expert, the ultimate expert in hypertension. So to answer his question, what does the high blood pressure say about your arteries? Well, it depends on how long you've had hypertension and why you have hypertension. But often, after many years of high blood pressure, your arteries are going to be getting stiffer and stiffer.
Yeah, let's see here. I was trying to find his question again. I lost it. Yeah, does blood pressure indicate how healthy your arteries may be? Was William's question.
Yeah.
It could. It can.
Yeah, they just because you have high blood pressure doesn't mean your arteries are not healthy. But the longer you have high blood pressure, the more damage the blood pressure will cause into the arteries and promote the development of atherosclerosis. I had never, like I said, I mean, I was 58 when I started having blood pressure problems. An interesting story adjacent to that, I was working for a company that did a lot of auto accidents and personal injury. And I was a 1099 employee. And I call in and I say, listen, I'm not feeling well. My blood pressure is very high. I'm not going to go in. I'm going to go and see my doctor. And the person I'm talking to, well, couldn't you do that on the weekend? I said to him, well, You know, the next time, I'm not going to go in today, but the next time I'm about to have a stroke, I'll schedule it for the weekend. I mean, how stupid can you be? And this is someone who was working in the doctor's office. Can I do it on the weekend? Listen, today I feel like I'm about to have a stroke, so I'm not going to go in. I'm going to have my blood pressure checked, because at the time I wasn't even on blood pressure medication. So I'm no longer on blood pressure medication, by the way. Carnivore got rid of that. And my blood pressure is 115.
Yeah, I was taking meds, and then my first year of carnivore, my blood pressure got down to, like, the meds would just keep me under 145/95. But then my first year of carnivore with meds, I got down to an average of 120/80, and I thought it was great. But
Now,
then
if I understand that correctly, Bob, you already had a kidney problem.
I did, yes, since
One year
2019. Yeah.
Yeah.
And then when my
Okay.
triglycerides spiked, my PCP put me on fenofibrate, and that actually undid my progress, threw me deep into stage 5, and then my blood pressure went back up. And now I'm off of that, and I'm trying to hopefully regain lost ground. You know, that's where I'm at right now.
What thyroid, Bob, did your doctor put you on?
It's called fenofibrate. It's for high triglycerides. So it's because when I lost weight rapidly on the carnivore diet, my trigs, which were at 700 on average for years because I had chronic kidney disease. Okay. When I lost weight rapidly, they went up to almost 3,000. And we always hear that triglyceride to HDL ratio should be 2 or less. I was 2,887 to 16. So my ratio was like 459/1. And my PCP flipped out. I was flipping out. I was coming online talking to all these carnivore doctors who really didn't have an answer. And I went on the fenofibrate out of desperation. And then I was on it for a year and then went back for some more blood work. And it actually made my kidney situation worse and my blood pressure went up. And I had to figure out for myself by going to PubMed and reading studies that the fenofibrate was the cause of that. So I went off of that. So now I've regained like half of my function that I lost, and hopefully over time I'll regain some more. But all my kidney issues come down to a decade of pharmaceuticals for this reason or that reason. So,
By the way, just a comment. Bill, I know you're raising your hand, so we'll take it in a second. But a comment on the triglycerides, the fenofibrates. Gemfibrozil was the first medication specifically among those fibrates. Lopid was the brand name. And whenever I saw triglycerides high, there were two things I did. First, cut the sugar and the carbs. Always brings the triglycerides down most of the time. But I used to use a lot of Lopid or other fenofibrates until I read a very large study by the VA, and this is a story similar to many of the cholesterol studies. The medication lowers the triglycerides, but did absolutely nothing to reduce all-cause mortality or cardiovascular event. So what am I doing? Treating the piece of paper where the lab is printed, not giving any real benefits to the patient. So I stopped years ago prescribing triglyceride, fenofibrates or Lopid, unless there will have to be a very specific circumstance. For example, someone who has gotten pancreatitis with very high triglycerides. Just to avoid the pancreatitis, I would use the medications. Otherwise, I don't use them anymore. They don't. The most important statistic of their many that you could look at, and if it doesn't decrease the all-cause mortality,
what's the point? Yeah, mine are down to 250 now with no fenofibrates, and and I've also been weight stable since November of 2023. So that tells me that, I gave my body time to break down these triglycerides and catch up. And so now I know that if I was to lose another 15 pounds rapidly, they'd go right back up, but in time they would come back down,
Yeah.
And I'm kind of less worried about it now than I was before because I don't eat cookies, cakes, pies, things like that. So, I don't fit the profile of why someone would normally have high triglycerides because I'm not a carb eater. So let's get to William.
Bill, go ahead.
I went to the doctor one time and went down this long hall.
I don't hear you very well. I hear you. I don't hear you very well. It's very low volume. Yes.
Is that better now?
See if you can raise your mic volume. You don't need to hear it better. I need to hear it better. So the mic, not the speakers, need to go up.
1 second.
Now, I'm hard of hearing, but I do hear well with these things on my ears right now.
Dr. Nelson, so what Bob was talking about too. Are we going to see a rise in triglycerides and some of these things? Like part of the reason it's transient is if people are
You
sick.
might not every. As a matter of fact, on a low carbohydrate diet, almost no one has that. It's actually something that happens, but it's more. It's kind of not frequent.
Most
But
people see
if
that.
there's a fast, but if there's a rapid weight loss because there's toxins that are in the fat cells, and if
Even
you
with
don't
rapid
let-
weight loss, you may not have an increase in triglycerides, but it can happen.
Yeah,
It
most
can
people see
happen.
it go down. Most people see their trigs
Yeah.
drop because that's the energy. You know, when we go back to that truck delivering the energy, the trigs is now your energy and no longer glucose. So it gets emptied right away, so you have low levels.
And it's very important to do the right amount of fasting before the test.
Yeah.
There are two tests. Even some doctors nowadays, I don't know. Oh no, it doesn't matter. You don't have to be fasting. No, you have to be fasting for two things: your glucose level, that fast can be 8 hours, and your triglyceride levels. That fast needs to be at least 12 hours. So the sweet spot is somewhere between 12 and 16. If you do it too soon, after you ate, what happens is, especially if you're eating a high fat diet, your triglycerides are going to show up as being high because a lot of the fat is directly going into a chylomicron and VLDL and transporting triglycerides and cholesterol straight to the cells, or your body's producing triglycerides because it was just fed, and they're going to be high, but they're not realistically high because you have to have everybody within the same circumstance. So fasting 12 to 16 hours is the sweet spot to be able to compare one sample to the other. But triglycerides can change. Even cholesterol, which is not thought to be a number that changes very often, it can change within a day. How do I know that? Ask Dave Feldman, who has done 6 to 10 measurements of cholesterol every day for a long time. But the triglycerides are very unstable, just like the blood glucose is. It's not that they're unstable. That's the normal physiology. They go up and down. All right, Bill, can you? It's not. I think I understand you enough, but you're very low.
Anyway, I go in. She did my blood pressure like immediately. Not my heart doctor, but the nurse. And it was too high. Did the EKG, and then my doctor came in and said it was perfect. What does the EKG actually do?
All right, so an EKG doesn't tell you anything about your arteries, by the way. Okay. The blood pressure being very high, first of all, you need to take your blood pressure. Sometimes, if you take it right away as you walk into the office and you haven't even sat down and you're all agitated and the blood pressure is normal, I wouldn't repeat it. It's normal. Under those circumstances, it probably will be better if you just rest and deep breathe for 5 minutes. But if it's high, you should have it repeated. And you only have it repeated after you've been sitting in a room, relaxing for a few minutes. I usually would wait no less than 5 minutes and turn the light off and tell them to do breathing exercises and relax. Then I come back and check it. Okay?
Right. Well, they did an EKG.
I understand, but did they do a second blood pressure? All right.
Then my heart doctor said it was a perfect. So I don't even know what that meant.
Well, sometimes we have to understand the limitation of tests. Yes, I would do an EKG on someone whose blood pressure is high to make sure they're not having a heart attack or anything that the heart may be causing, influencing the blood pressure. But a normal EKG doesn't tell you anything about the blood pressure unless it's causing any changes on the EKG. So, I mean, you take into account the patient's history or denial of a chest pain or shortness of breath with exertion and all these things to determine if there's anything acute going on. And then you repeat the blood pressure. You don't ignore it. If I repeat the blood pressure under the right circumstances and the blood pressure is now normal, then I don't worry as much.
Yeah, I'm not worried about it now, but I was just trying to figure out why they had to do an EKG.
I would have done it too. If your blood pressure is truly high. Now, I would have taken that blood pressure 2 or 3 times, not just once. if it's high, it's warranted to do an EKG, just making sure. It's one of the many things a cardiac event. Well, it happens to be the #1 killer in the United States, so you don't want that to happen in your office. All right, if there's no more questions, we're gonna leave it here. Thank you for being here.
Thank you, Dr. Nelson.
But if there's any last questions, say it now or forever keep your peace, okay? But otherwise, Bob, Jen, Sharon, Nancy, Diana, Bill, Cheryl, Kimberly, the other Sharon, Kathy, Joe, Stephanie. Are you here, Stephanie? I've been seeing your picture, but I didn't hear you. Jerry, and that's it, I think. All right.
Thank you, Dr. Nelson. Bye, everyone.
Yeah, thanks
a
for
good-
the long class and for staying over. Appreciate it.
Glad I could make it today.
All right. Bye-bye.
Enjoy your trip. Enjoy your trip tomorrow.
Thank you very much.
Bye, everybody.